So welcome. It's my pleasure to introduce Dr. Andy Hulet, who is the resident who is going to lead off today talking about technology and orthopedic education, and he's going to be followed by Dr. Kennedy. As you all know, this is near and dear to my heart and has become a really important topic. There are some programs around the country, such as University of Wisconsin, where Paul Anderson is, that have really embraced this technology and incorporated it into their resident education and training and research. I think you've all heard me talk about it. It's one technology that can unite all four missions of the department. Our financial mission, our clinical mission, our research mission, and also our educational mission. So I'm really excited to hear Dr. Hulet and Kennedy talk about it.
Thank you, Dr. Chansky. So yeah, I'm Andy Hulet. I'm a fourth-year resident. Today, Dr. Kennedy and I will be talking about technology in orthopedic education. And neither Dr. Kennedy nor I have any disclosures pertaining to the technology we're going to be talking about today. So for centuries, surgery has been taught using an apprenticeship model. And in order to become an orthopedic surgeon, residents have to learn vast amounts of medical knowledge, and they have to acquire surgical skills to practice in an increasingly complex and technically demanding field. Surgical training is frequently compared to the airline industry. When we step on board an airplane, it's not enough that the pilots understand the way the airplane works, all the different gadgets that they use, the anatomy of the plane, if you will. When we step on board, we expect that the pilot can actually fly the plane every time. And flight simulators allow pilots to practice and, frankly, to crash as many times as they have to in order to learn how to safely respond to a given situation. So they get to practice until they get it right. Unfortunately, most orthopedic residents in training don't have that luxury and are in learning mode much of the time that they're in the OR. When we graduate from medical school, we recite the Hippocratic Oath, and we say, first, do no harm. But how do you balance that with actually being able to learn how to do the surgery? We have to learn these really complex skills, and we have to be able to get better at those, but we can't afford to make mistakes and harm our patients. Historically, our attending standing next to us, watching us like a hawk, making sure that we don't make those mistakes. That makes the resident nervous, that makes the attending nervous, and that leads to stressful situations, which sometimes leads to harsh feedback. And some believe that contributes to poor confidence, lesser performance, and burnout. So simulation has been used in the airline industry for decades. And so why hasn't it been the same in surgery? It's been picking up, but the simple answer to that is just that surgical training is decades behind. With regard to competency, and using arthroscopy as an example, the ACGME requires each resident to maintain a case log of procedures performed, but doesn't specify a certain number of total cases required for arthroscopic proficiency or competency, and that's probably because it's different based on for every individual. But neither the AANA nor the AEOS has guidelines regarding that necessary number of procedures to mean competency. But both recognize that completion of ortho residency doesn't necessarily equate to competency in arthroscopy. In 2012, Pedowitz and Marsh et al. Postulated that in the coming years, surgical training would change dramatically and move toward more objective, proficiency-based approaches, which in the end would improve patient safety and educational efficiency. And since then, we've seen an increase in simulation technology, which is making it possible for residents to acquire surgical skills in a safe environment where errors are not only acceptable, but embraced as part of the learning process. And so we've seen a paradigm shift away from the traditional apprenticeship model, and that's because of several factors, including growing concerns about patient safety, increasing public awareness of medical errors, heightened patient expectations, cost pressures, operating room efficiency, work hour restrictions, and the need to acquire increasingly complex surgical skills in less time. And so with this paradigm shift, we're seeing an increase in the incorporation of simulation. Ortho generally lagged behind other surgical specialties with fewer validated simulators available, although that trend is changing. An acquisition of surgical skills through simulator-based training is demonstrated by two key concepts: transferability and retention. Transferability is ascertained when the skills learned by simulation-based programs are transferred to actual performance in the operating room. And then skill retention is the de facto indicator of later performance. We've all learned by experience that our retention of information depends largely on the nature of our involvement, with active learning being much more valuable than passive learning. And it's believed that people generally retain about 10% of what we read, 20% of what we hear, 30% of what we see, 50% of what we see and hear, 70% of what we say, and then 90% of what we say and do, like doing a dramatic presentation or simulating the experience, with obviously doing the real thing being the best way to learn and remember the information. In general surgery, simulation-based training has been successfully integrated into residency education for years now. And there's been randomized controls trials from the general surgery literature that have proven that simulation-based training leads to detectable benefits for learners in clinical settings. And alternative surgical skills training methods have been adopted since the early 2000s in orthopedic surgery as well. And studies have shown that 30-day intensive surgical skills courses, similar to the one that we do here, can be an effective means for interns to develop targeted basic surgical skills with improved outcomes on the OSATs and the global rating scale. Cadaver training has been an integral part of surgical education since the 16th century, and it's remained a benchmark of trainee surgical practice before beginning to operate on living patients. And all of us know how valuable having access to cadavers is. It's extremely valuable. We all find it very beneficial. There are some disadvantages, however, which include the costs, difficulty in procurement of cadavers, limited repeats of the use of a cadaver, and then also the small possibility of disease transmission. In the latter half of the 20th century, synthetic or plastic bone models, or sawbones, were developed to help with basic ortho surgical skills. And the disadvantage with these, obviously, is the lack of realism, lack of that soft tissue surrounding the structures. However, these still remain important in training, especially in simulation of fracture fixation. And we use these a lot in like our AO basic course. One of the biggest challenges in residency, for residency programs, is difficulty of incorporating sufficient arthroscopy training into the curriculum while limiting the adverse consequences related to time constraints and patient safety. And there's serious concerns regarding resident proficiency in arthroscopy, and evidence indicates that many ortho residents are probably graduating unprepared to perform arthroscopic procedures. And as residents, the last thing we want to do is, in the words of Dr. Thompson, leave doctor tracks in the patient's joints. But we have this really great arthroscopy boot camp that's super helpful, and it's made a big difference in training outcomes in arthroscopy here. And as you can see, it's really fun as well. And we also have software simulators now. This is the Symbionics arthroscopy simulator that we have at UWMC. Simulators like this one allow for practice of arthroscopy skills in a safe environment. I found this machine particularly helpful when I was a junior resident, just to kind of help me become familiar with the arthroscopy technology, with the equipment, with developing triangulation skills, being able to probe and track. And these machines are getting better and better, and a lot of them you can actually go in and practice doing surgical skills as well before going to the OR. And over time, these have become more realistic, and they just keep getting better and better. And most of these have an incorporation of haptics, which haptics can be defined as the simulated feeling of touch. There's two different types of haptics, active and passive. Active haptics is a computer-generated feedback that, for example, when you touch with the tip of your probe or you're using your shaver, the computer will provide feedback into your hand. Passive haptic feedback is just basically a constant signal sending to you, like you're feeling that in your hand. But the disadvantage is lack of realism, and sometimes, as many of you who've used this machine know, it can be really frustrated. You might be like gently probing something, but then it will like start shaking and pull your hand into the joint, and then you see your score go like, meow. So that can be a little frustrating. Virtual reality is a cool new technology which allows trainees and surgeons to practice certain procedures or become familiar with new devices in a safe virtual environment. This is the OSO VR system that we have at Harborview. It's a really cool new technology that allows you to practice and learn different devices before actually using them in the OR. So instead of having to memorize the technique guide, you can actually practice with different devices and the steps on those. So we've made great developments in the technology of simulation, but there's still a big concern regarding the validity of the skills learned on the simulator and whether they can be easily transferred to the OR. On one end of the spectrum, some attending surgeons think that simulators represent little more than a means of evaluating a subject's dexterity or aptitude for video games. But on the other hand, concern exists that it only provides psychomotor skills training and doesn't really assess the cognitive components like knowledge and decision-making and communication. And so research into proxies of learning is improving, but more work is required to identify the best proxies for a given procedure. Several studies have attempted to address the effectiveness and transferability of simulation practice to the OR. This study by Howells et al. Out of the Journal of Arthroscopy in 2008 showed that trainees who have undergone a period of lab-based arthroscopic simulator training go on to develop improved technical performance in the OR compared with those who didn't have that simulation training. And then a paper out of JBJS in 2011 showed a strong correlation between the performance of basic arthroscopic tasks on a simulator model and then performance of those same tasks in a cadaver. Learning curves are becoming commonplace, but are poorly integrated into postgraduate training curricula, and there's little agreement over how exactly those can be applied to analyze learning curve data. This is a figure from a paper by Dammer et al. Out of the Journal of Surgical Education in 2018. And they had people they had like new or senior medical students who didn't have any training, any surgical experience, and then residents who had a couple of years of surgical experience, and they had them practice on a knee arthroscopy simulator. And as you can see, the learning curve was just much steeper. Like the people who had no experience, the student group, had a steeper learning curve, and they had a significant improvement in terms of time, the distance traveled by the camera and the distance traveled by the probe. And so more experienced users can improve their skills with these simulators, but the learning curves will be flatter because they start from a different point than the people with less experience have. And it's not just arthroscopy simulators. There's a lot of really great simulators now in various different aspects of surgical training. This paper recently published in Core looked at whether the skills from training with a wire navigation simulator transfer to a mock OR environment. And they asked two questions. They asked which training methods between their didactic group, deliberate practice, or proficiency-based practice leads to the greatest improvement in performing a wire navigation task. And then does performance on the simulator correlate with a higher simulation task in the mock OR? And they had 3 different groups, and they actually had 55 residents at 4 different medical centers, Iowa, Minnesota, Mayo Clinic, and Nebraska over the course of 2 years. And they had 3 groups as seen here. So the first group received a didactic introduction, and then they went straight to the mock OR. So the second group had a didactic introduction, but then they got to go and practice deliberately on a simulator. They took a simulator assessment, and then they went to the mock OR. And then the third group had the didactic instruction, but then they got to practice on the simulator until they became proficient on the simulator before taking the simulator assessment and going to the mock OR. And this is just showing their simulator. It's pretty small, pretty simple. You can just plug it right into a laptop. And here's an example of feedback as they're trying to pin this hip. It says like, the wire is angled too anterior. Rotate your hand by approximately 9 degrees to correct the trajectory in the lateral view. This is just another example of the feedback given helping the resident to identify the center of the femoral head, the center of the femoral neck, and the correct start point. And then this is just more feedback in the proficiency-based group. If the resident needed to adjust the start point or change their trajectory, it would show up in red like this, and then once they got it right, it would turn green. And then this is just showing what their mock OR looked like. And they found there was a lower tip apex distance in the 2 simulation-based training groups compared to the traditional group. Interestingly, they found that the proficiency training group used more images, and they believed that was probably because they had practiced so much on the simulator getting the exact perfect start point and trajectory that they ended up just taking more shots to try to get there. And then they found that in the simulation-based groups, performance on the simulator was correlated with performance in the mock OR. So they concluded that emphasis should be placed on providing an environment that allows for deliberate practice with immediate feedback about the performance. And then they talked about how this simulator is one that offers a safe environment for residents to learn the key skill of wire navigation. Another paper by Hooper et al. Out of the Journal of Arthroplasty in 2019 looked at the effectiveness and transferability of virtual reality simulation of total hip arthroplasty. This was an interesting study. It was a blinded randomized controlled trial. And they asked, does the use of VR simulation improve an intern's performance on a cadaver total hip arthroplasty? And then does the simulation have a preferentially beneficial effect on surgical aspects of surgical, or certain aspects of surgical skills or knowledge? They had 14 interns. Each of them took a written pretest and completed a single cadaver total hip arthroplasty to establish a baseline. And then 7 of those were randomized to a virtual reality total hip simulation or not. The randomized group did 2 virtual reality total hip arthroplasties, and then all of them did a second total hip arthroplasty, and then retook the test to assess for score improvements. And they found no difference in improvement in test scores between the groups. The virtual reality cohort demonstrated significant improvement in overall cadaver THA scores. And then there was a significant improvement in technical performance in the virtual reality group. So they concluded that virtual reality simulation improves intern surgical skills, but has no effect on medical knowledge. And the most significant effect they found was on the improvement of technical skills. And this study by Gumal out of Harvard, which was published in the American Journal of Sports Medicine in 2017, looked at the correlation between surgical experience and performance on a virtual reality simulator for shoulder arthroscopy, and this one was pretty interesting. So they had 4 different groups. The first group was like brand new interns who didn't have any surgical experience. Second group was PGY 2s and 3s. Third group was 4s and 5s, and then the fourth group was fellows and attendings. And then they also looked at video game experience. And they evaluated them for time to completion, distance traveled with the tip of the simulated probe compared with the computer-determined optimal distance, average probe velocity, and the number of probe collisions within the tissues. So as you can see here, comparing the least experienced with the most experienced group, the average time to completion decreased by 62%, from 128 seconds to 49 seconds. Similarly, the path length of the probe and the camera decreased by half from the least experienced group to the most experienced group. And then probe collisions also decreased by half compared between the most experienced group and the least experienced group. And then average probe velocity more than doubled from the least experienced group to the more experienced group. And they found no significant difference for any parameter between video game experience, those who had video game experience and those who didn't. So if any of you are justifying that you're practicing your arthroscopy skills by hardcore gaming, you're probably not. So they concluded that the skill set tested by this simulator may be similar to the one developed in the operating room, thus suggesting its use as a potential tool not only for training, but also for evaluation of surgical skills. And with that, I'll turn the time over to Dr. Kennedy.
Thanks, Andy. I'm Stephen Kennedy, one of the hand attendings. For the last 2 years, I've been the chair of the Clinical Competency Committee that evaluates the competency of residents for graduation, and I'm also one of the 3 associate program directors. I wanted to talk about technology in orthopedic education today because this fall I was asked to represent our department at a consensus meeting at Hospitals for Special Surgery on the role of simulation and digital learning in musculoskeletal education. It involved orthopedic programs from across the United States. There was keynote presentations from experts in education and as well as simulation. I learned a lot about where we are now, what other programs are doing, and trying to work towards what are best practices. I also immediately followed that with attendance at the AOS Orthopaedic Educators course. Dr. Tatesman is one of the faculty for that course. It's very helpful. A lot of practical information on teaching, learning, and program development, which is essential for this also. So where are we now? Well, one thing that I learned from the presentations was that UW Orthopaedics has been an early adopter of education technology. We have been using education technology since the early 2000s. Since 2011, we have been providing our orthopedic residents with iPads loaded with multiple software apps to improve their educational experience. Many residents are using digital notebooks and or personal wikis to store their information, what they learned from their surgical experiences, their educational experiences, and organizing it and reorganizing it in ways that make most sense to them. They're also using software to save their various papers and review articles to maximize their learning. Residents have access to a variety of multimedia apps, free apps. There's also some paid apps that the department pays for. And there's also access to 3D printers, and we're seeing increasing use of that day to day. One of the take-home points that I took from the consensus meeting is that often the most popular tools are shared drives for resident use. So there's a lot more organic approach to learning in many different programs, and some are actually moving away from providing their residents with the hardware in preference for providing them with more software options and letting residents choose whichever devices they want to use to access that information. Online study plans and test preparation seem to bear success on the OITE. You may be familiar with OrthoBullets. OrthoBullets has test preparation materials. There's also JBJS Clinical Classroom, which is associated with the New England Journal, and they provide similar information with a slightly different approach. The preferences and performances around the OITE, or the Orthopedic In-Training Examination, are an active area of study. There's some offshoot studies from the consensus meeting looking at study hours and practice questions. How do residents prepare? How do they prefer to prepare for the OITE? Is one method more successful than others? Are people just good test takers? We do see that people who did well on the USM Elites seem to do better on the OITs and then also on the board examination. But are there things that we can do to help maximize residents' experience and maximize their knowledge? One of the big takeaway points from the educators course is that what we teach is not necessarily what is learned. And Andy talked a little bit about this pyramid of learning, and there may be some concerns about the actual statistics, about the actual numbers here, but I think we can all probably agree that this makes sense, that listening to a didactic presentation where somebody's at the front of the room giving you, trying to transmit knowledge is going to be less effective than being an active learner and participating in that. And so a lot of programs are moving towards flipped classroom models where instead of giving the didactic presentation on the day of, they're recording it as a video, presenting it to the residents so they can reach it online through YouTube or other video assessments. And then the classroom time is spent more going through cases, having an interactive discussion. Socratic teaching can be effective with minimal technology at all. And a lot of that has to do with figuring out where the resident is at and then helping them bridging them to the next stage of their learning to maximize learning experiences. And we can use technology for this also. At the AOS Educators course, we talked about using different types of software. One option is something called Nearpod. This is software that's designed for K-12 education, but although it was designed for kids, many of the applications are excellent for teaching residents. So I had a distal radius fracture presentation that I've been doing for a few years, and I decided to switch it up in November and did it as a Nearpod module. And it's great. So you can ask open-ended questions. Residents can use their phone, their computer, their iPad. They can submit answers. They can show up on the screen, and then you have an opportunity to discuss what people are saying. You can also, instead of having one person going through the X-ray, you can have everybody in the room trying to draw out the line. So this is an example of asking residents to draw out the radial inclination of the distal radius. And it can be very illuminating, both for the learners, but also for me as a teacher. I think I learned more about my learners in that one presentation than I probably did in several years of doing that presentation, because I realized how different the levels of learning. I'm teaching people from medical students all the way to fellowship hand surgeons, and so there's a lot to learn on both sides of that. You may have heard of TED presentations. Well, TED Ed is another option that you can use to kind of take your presentations to the next level with polls, quizzes. You can have games that residents can use, and this can be done both at the time of the presentation, or it can be done independently. Mike Ithens has also been a proponent or has been quite active on Instagram, and educational experts refer to this as micro-learning. Sometimes people say, oh, the new generation, they don't want to, as soon as they're out, they're out, they leave the hospital. But he is engaging with residents across the globe who are really interested in learning more, seeing interesting cases, picking up tips and tricks in a brief encounter on their phone or on the computer, and then moving on to their next thing in their lives. Technology can also help systematize effective teaching that's already being used. Many of our faculty will brief with a resident before a surgical procedure, do some intraoperative teaching, and then do a debrief afterwards. Well, that information can be very valuable for a program. So in 2014, Aaron and Dr. Hanel and some residents developed this app called eMetrics. And this has been adopted by multiple other programs, including programs in other surgical specialties like cardiac surgery, and has been very popular because it basically augments what people are already doing. And yet residents are still graduating inadequately prepared. If we look at we don't have data in the orthopedic, we have some limited information for orthopedic residents, but in general surgery, many general surgery fellowship directors feel that trainees, when they arrive for fellowship, are inadequately prepared. In a survey of fellowship program directors, 66% felt that incoming fellows were unable to perform 30 minutes of a major procedure. 56% could not appropriately suture, and 28% were not familiar with therapeutic options and surgical indications. So are we making adequate use of these technological resources? Are there things that we could be doing to better encourage milestone feedback requests? For the Clinical Competency Committee, sometimes we wish we had a little bit more information from these sort of apps. And is there something that we could do to encourage residents to initiate more of these evaluations? And also, are there things that we can do to have faculty participate more in these evaluations? And this is a nationwide issue that from this consensus meeting, I learned that basically all programs are going through this same sort of dilemma. Another common dilemma amongst many programs is that departments pay a lot of money to have expensive simulators, and they can sit in rooms unused. They can be put in a place that's kind of not convenient for residents to use. That something can go wrong where something's broken and it doesn't get fixed. There's multiple different reasons, but that is a common problem that people are experiencing also. So how do we avoid a triumph of technology over reason? People talk about becoming an expert, and you might, in cocktail parties, people talk about 10,000 hours to become an expert. But 10,000 hours only works with deliberate practice. The hours alone are not enough. So Scrabble champions don't just play Scrabble with their friends to become experts. They learn the mathematics and the statistics behind it, word patterns. Chess grandmasters don't just play chess with other chess players. They study the key moves and or other key aspects of the competition to improve their skills. And it's the same for orthopedic residents. We need deliberate practice. It needs to be goal-oriented. Residents need to stress beyond their current abilities. They need to have something that's demanding mentally. There needs to be immediate feedback, and it needs to be repeated frequently. Residents learn within a zone of development, and that's an important concept for kind of all of this education, is that you need to target the rate-limiting steps for residents at different levels of proficiency. So if faculty are noticing that there's specific things that continue to be an issue for different resident levels, then that would potentially be an opportunity for surgical simulation to bring people to the next level. So figuring out what the zone of development is for a resident and then helping them get to the next stage is a key aspect of using surgical simulation or education technology. Targeted learning is already being used for orthobullets and the JBGS clinical classroom or other educational modules. Basically, these are adaptive learning systems where they take into account what the resident already knows, so they don't teach a resident a lot of what they already know or teach them stuff that's beyond their level. Figure out where they're at and then increase learning in that specific area to bring them to the next level. Simulation doesn't actually have to use expensive technology. Technical skills training has been used, by, as we heard earlier, by general surgery for many years. They are well ahead of us. They have low fidelity and high fidelity models, including laparoscopy trainers, and many of our residents participate that during their internship, during their EVATS rotation. And I think this is an opportunity for us to potentially develop more of our own orthopedic style simulation trainers. We have been using sawbone simulation courses for many years, both through the AO and also the OTA, other specialty societies. We also have local events where we use Sawbones. Sawbones is actually located on Vashon Island, the Pacific Laboratories, so they're a local company. One of the highlights of the residency that we hear from consistently is the arthroscopy boot camp week. This is much loved, and also residents find it very fun, but also that they learn quite a lot in that experience. We talk a lot about learning curves, but we probably don't talk enough also about forgetting curves. So repetition or application of the knowledge is necessary to maintain retention. Some people estimate that we forget about 80% of what we learn within 30 days if we don't have some kind of conscious review. There's some, different variations with this about how powerful the learning is and how engaged we are. But regardless, if we don't use these skills in some sort of way moving forward, a lot of them are forgotten. And high fidelity models may not always be necessary. So as long as a skill can be learned to proficiency and transferred to the clinical or surgical environment, that may be enough. High fidelity or immersiveness may be unnecessary. It may be more fun to have a really immersive simulator, but if it doesn't meet the goals of what you're trying to achieve, then it's not going to be very helpful. And so there may be advantages to repetition that favor low-cost options. In the Hand Society, there has been a program over the last couple of years to try to develop a surgical training and education platform, or STEP. This simulation curriculum for hand surgery is intended to be a low-cost option, so have low-cost materials available easily online and in hardware stores, so that fellowship program directors can have modules for their fellows to maximize their learning. For example, there are these I didn't realize this until a year or so ago, that some people buy these inexpensive scopes to put them in their ears to clean their ears. Well, that's actually, if you take that and kind of match it up with a box and try to do some triangulation, you can have a very inexpensive arthroscopy simulator. I purchased one of these, and it's kind of cool. For like $20 on Amazon, you can have a little arthroscope to practice on at home. You can also use for microscope training, putting a smartphone on top of a little stand, and then having an inexpensive set of microscopy instruments. You can practice microsurgery outside of an operating room environment at home for very little cost. One of the coolest presentations at the consensus meeting was from Catherine Barsness et al., and she kind of talked about that models can be synthetic, biologic, or hybrid. And so she was particularly interested in cases that pediatric general surgery fellows may not see during their fellowship. She wanted those fellows to be able to get that experience, even if they couldn't get it in the operating room. So she worked with experts with 3D printing, and so she developed 3D printed models for infant rib cages. And then she went and spoke to some representatives from a slaughterhouse and learned about the availability of fetal bovine tissue. And after doing some dissections, she realized that there was some ideal tissue within the fetal bovine tissue that basically looked exactly like what she saw, for example, duodenal atresia. The narrowing between the multiple stomachs of a cow looked exactly like what she would see in a pediatric general surgery case. And so by combining the 3D printed model with the fetal bovine tissue, she had a very high fidelity model for her residents and fellows to learn from. And this has been expanded to multiple programs in pediatric general surgery. But you've heard multiple different models now. And there are multiple things happening in our department looking at different surgical models, but program planning is critical. The American Board of Orthopedic Surgery has recognized this, and in 2013, in July of 2013, the ABUS mandated the introduction of simulation training to improve surgical skills in orthopedic surgery residency programs. So they mandated that that each program has established goals and objectives, as well as assessment metrics. They need to provide training in skills used in the initial management of injured patients, basic operative skills to prepare residents to participate in surgical procedures, and a space dedicated for this activity is required. And in future, there's some discussion about potentially having this as a component of ABOS certification and potentially recertification on psychomotor skills. So the ABOS website has 17 modules. You can take a look at these yourself. There is latitude left to how they get modified for each program and how they are implemented as people see fit. And there's going to be some changes in these going forward in future. Assessment and accountability drive learning. For simulation to work, many programs agree that we need to make it count. It can't just be for fun anymore. It can't be something that sits in a room and we hope that residents go and use. It needs to start to become part of the curriculum. At Hospitals for Special Surgery, they have an annual event where residents participate, and it started out as just being fun, as a fun kind of competition between residents, but now it's become part of their curriculum, and it's actually part of how the residents are evaluated. So if it is going to become part of how we evaluate residents, we actually have to be very critical about how we're using that assessment to make sure that it's valid. There are multiple ways to do this, from as simple as questionnaires to the participants. Probably the gold standard is still objective structured, or OSATs, which are objective structured checklist, plus a global rating scale. And basically in preparation, the person creating the module develops the key parts of the surgery that they think are necessary for a person to be proficient in that surgery, and then an overall global rating scale to see how well they're doing. Other options use a global rating scale alone, just a kind of a subjective assessment of overall how they think that the person performed. There has been some work in our department and also in other departments on looking at crowdsourced assessment of skills. So taking video clips of what the learner has done, putting it on, uploading it to the cloud, so to speak, and then having crowd workers evaluate how well people are performing based on their set metrics. And in many cases, they can perform similarly to what, for specific tasks, and can perform similarly to an attending surgeon. And so without having an attending present for this surgical simulation practice, the resident could get some feedback. Motion tracking, we heard a little bit about that. That's kind of still in ongoing development. And then video recording for time shifting and also self-assessment. And then ultimately, we want what the learner is doing to actually be meaningful for what they're achieving. So if a resident could look really slick and meet all the requirements of doing a flexor tendon repair, but if I pull on it and it comes apart really easily or the knot falls off, then it's not, obviously not, they're not really achieving the goal. So having some kind of objective metric tool is also going to be built into many different models. And so we have to have ongoing review of these models to ensure validity. So when Dr. Barsness talks about taking her 3D printed and hybrid models to different residency and fellowship programs, she listens to what's going on. She observes what people are doing, and she takes feedback, and also assesses the transferability of these skills to the operating room environment. And if people are telling her that there's like little workarounds that they're doing to achieve the goal that doesn't really meet the clinical goals, then that's an opportunity for her to change the model. And one of the great things about, I asked her when I was at the meeting, like, once you've got this model, it must be cheaper to make a mold than just make a multiple number of these torsos. And what her feedback was is that one of the great things about 3D printing is rapid prototyping. So every time that she does a presentation or has fellows try it out and she gets some feedback, that's an opportunity for her to change the model. So she has tinkered with the 3D printed model, I think 27 times or something like that. So surgical simulation is not the future, it's now. We need to continue to adopt and adapt technology in education as we have been in this department for many years. We don't need to reinvent the wheel where viable models already exist. There's multiple resources. People have described multiple different things that we could be using. We need to make it fun or gamify where possible, but we also need to make it count. And then we need to implement these models and then validate them for future use. Thank you. I wanted to leave some good time for questions and discussion because I think a lot of people have some great ideas in this topic.
Thank you for the excellent presentations, both of you. Really enjoyed that. So, like most people in this room, I grew up using, physical textbooks, and I was just curious. And I have a hard time retaining information when I read it on like a computer screen. I tend to print things. Do you know if in education, if there are studies looking at retention of information, whether it's via electronic versus paper, and if that is just a generational thing that we experience if we're used to one way? Whereas, like, if you grew up using electronic sources, that you retain that information more easily than someone who might not have grown up with that?
I'm not familiar with anything about that.
I didn't come across any studies like that, but I've also wondered the same thing. It's been interesting.
I can tell you that my wife and I have looked up some of this, having raging debates with our kids about their methods of studying, and you can find evidence to support either view. I'm like Mia. I cannot read off of an iPad or computer screen and really retain it.
Interesting. Any other comments?
My kids insist it's generational.
Lots of luck with that. So one of the things that you brought up at the very beginning is pilot training. And, pilots are required to recertify every now and then, right? They have to go back in the simulator every few months or every year. Is there anything like that that shows that works for surgeons, for attendings? Because, once we're out, we're out.
Yeah.
And more people get themselves videotaped, swinging a golf club than videotaped operating, for example. So is there any data out there at all on maintaining proficiency?
Well, I know that Dr. Van Heest was at the consensus meeting, and there has been some discussion about that at the ABOS, so that maybe in future. But I think that the difficulty is that the current models for orthopedics are just not as sophisticated as they are for airline training. So I don't think that's going to happen in the immediate future. But.
Okay. So there's nothing out there one way or the other? As far as
not that I'm not familiar with.
Okay,
Yeah.
interesting.
Some of the studies like that one I was showing suggested that could be because of the association between, experienced surgeons, how just going to a simulator for the first time, they tend to do better than like the new interns. So we're seeing that association.
Okay.
But, and I think that's the idea that conceptually the simulators could be used to help do those assessments as well as train. But like he said, I think that's the big downside is that the simulators aren't realistic enough yet.
Gotcha.
The other thing that it comes up is that for that example, for flying a plane, and for we talked about like chess grandmasters and Scrabble champions. Like they said, those characteristics are very kind of delineated. Once you are very familiar with a specific plane, the simulators are designed around a certain plane, and you can become an expert in that kind of plane. But with orthopedics, things are constantly changing. Like in the course of a single residency, you might, metal on metal is the way to go, and then within a couple of years, metal on metal is out. And so, or like I learned, one of the minimally invasive techniques that I learned for total hips as a resident. By the time I became a chief, nobody was using it anymore, and I had these detailed notes about how to do it, and it's still useful to some extent, but it's orthopedics is constantly, medical profession is constantly changing. There's so many other factors to consider that it's not as constrained as these other models.
Okay. And what about, have people looked at visualization? Because if you're an athlete, if you're doing a ski run, you're thinking it out before you do the run, or if you're I don't know, rowing a race, like you're visualizing it ahead of time. Is there anything like that in surgical education? You know, where you have somebody develop a process of visualization so they can think through the operation. Is there anything like that? I mean, I don't know. I'm just asking.
I'm a believer in it, and I've been teaching residents to do that, and I think it's helpful. I think there's great benefit to visualization before surgery, doing the surgery, and then doing the dictation or visualizing it afterwards. But I can't give you any data.
Okay. All right.
Yeah, I didn't see any studies specifically talking about it, but Dr. Kwan, that's something he always talks about is like doing the reps and also like the mental reps. I think a lot of us find a lot of benefit in, you know, even for me, just like in the drive-in, if I know I'm going to be doing a specific procedure, I try to like go through the steps in my mind, and just even the mental reps helps a lot with actually doing that. So we all find it helpful, but I haven't found any studies that specifically looked at that.
Well, I think a lot of this is in its infancy, and some of the questions that you're asking are really critical questions going forward, and great opportunities for us to study, specifically in orthopedics.
All right. Great. Okay, thanks.
So good, you guys. Thanks for that. I had two questions. One was, what do you guys think is the reason? Because we see this all the time where we're evaluating or talking about a resident, and there'll be a group of faculty that say they don't get it or they struggle. But then when you look at the e-metrics and all the things we look at, they're 4 out of 5 are competent across the board. So what do you think goes into the disconnect that we have between some of the metrics that we use to demonstrate competency and the gestalt feeling that faculty or junior or senior residents might have about somebody's performance or competency?
That is opening up a can of worms.
Yeah, it is opening a can of worms. We discussed that at the meeting, and a lot of other program directors are going through that same dilemma. And one of the theories proposed is that although people want feedback kind of on a psychological level, people probably request feedback at times when they did a good job. If there's like some opportunity to choose, it's just in human nature that if you had a kind of a case where you struggled and you have a choice of whether you're going to initiate any metrics or not, there's just the risk of psychic harm. You really don't want someone to come down on you with your evaluation, so you may not submit any metric in that situation. And so, and that's not just our program. That is like across the board. Every program is going through the same thing. They're having difficulty. They may not use e-metrics, but a similar, a program. And so that's a challenge for us to sort out. And then also, if you look at the levels of burnout amongst faculty, I mean, faculty have across the country with rates of burnout, approaching 50%. There's faculty have a lot of other things going on in their mind, and it may be one additional thing that they just may not kind of reach to do to the full extent that they would otherwise want to do in an ideal world. They've got clinical demands, research demands, family demands, a lot of other things that are kind of can interfere with that. So it does kind of open a can of worms.
I guess I'd like to use that as a thing for the residents. Is I find that as well. I get the e-metrics requests when the case went good or when people feel good about it. You should submit them when you feel bad about how the case went or your involvement in it just didn't feel good. Like those are actually probably more helpful to submit the e-metrics. And then the second one, I guess not more of a comment, is at the CORD or Council of Orthopedic Residency Director meetings, we talked about how there could potentially be a trend or a move away from the metric that we now use is the resident was able to put the fixation on for the ankle fracture, and instead the metric being, do you trust the resident to do fixation for an ankle fracture? And whether it was like a competency or proficiency based, a checklist based thing versus something else that incorporates more that feeling of whether they're getting it or they're trustworthy or they're growing.
So you're saying that there might be a move away from actually objective.
A checklist of proficiency I saw them do the arthrocentesis, or they did it 10 times to a proficient level and moving the pendulum, kind of moving possibly a little bit away from that to something more like, I trust Andy Hulet to do the arthrocentesis in the shoulder, and whether it was because they saw them, we saw them do it once or 10 times or 20 times or maybe 0 times because we saw them do it in the knee or the ankle a million times. I think there's a move towards that.
But I mean that's hard too, because we've all seen residents go through programs where they have the halo effect, or where some residents they do an outstanding job in their first, second year, and then for the rest of their program they can basically do no wrong, and it can be hard to kind of provide them with critical feedback that will actually help them get to the next level. So it's like, probably some mix of that is what's necessary.
Hey, this was great. Thank you very much for that presentation. I'm a little bit ignorant when it comes to the resources in the university at Harborview, at the U. Even at Children's, we're starting to have simulation opportunities. I'd love to get a list of where are these places where the simulator is. I'm not sure of all the opportunities. The Wish Lab, I get regular flyers from them. So I hate to ask a question that brings more work on anybody, but it would be great to learn of those resources.
Yeah, I think that Dr. Chansky has been talking about this as well, to try to structure this and try to coordinate, to develop some more coordination, to have a central repository of that. So there may be more info on that to come, to try to coordinate it best, so we can find out, because there are some great ideas from multiple faculty members doing different things, and there's a potential for us to overlap. Aaron has also been working on some of the technology with 3D printers, including some soft tissue 3D printing. So I think that there's some really cool opportunities and some existing.
It probably has to be dispersed, but so people have easier access to it, but it's very expensive. I mean, our arthroscopy simulator was, I think, about $225,000, and the half-life of these, because of the technology, is pretty short. And so I think there's a fine balance between sort of just wasting money and versus really trying to be efficient and centralizing things versus having duplicates everywhere. So I think as a system we need to sort that out.
So great presentation. So along the lines of Dr. Kwan's question, I think for arthroscopy it's pretty easy to quantify speed. I think how good your knots are, and also economy of motion, also microsurgery as far as patency and speed. But even looking at the milestones for orthopedics, distal radius and carpal tunnel from the consensus meeting, are there any thoughts on how do you quantify some of these skills? It is pretty arbitrary. They get a 4 out of 5, 3 out of 5 for distal radius fixation. How do you quantify the dissection, the fixation, and just kind of the thought process, execution out there? Any thoughts on kind of moving forward? How do we try and objectify that process? How well do you do a distal radius or ankle fracture? Or
I think that also opens a can of worms, because in many cases sometimes we as faculty, we don't completely agree. You have some, Jerry, you have some things with the way that you do distal radius fractures that might be different from mine, and so you kind of have to, when there's a discussion from multiple faculty, you kind of have to have a little bit of humility too, and take out some of those things. Like if you're the person that always repairs the pronator quadratus when you're closing a distal radius fracture, but then someone else says they never do it, maybe that's not a critically important objective for the residents to achieve, and maybe there's some other things that that we can agree on that are important. But for each of these, from what we're reading, is that for an objective, for the OSAT scores, it needs to be specific to each procedure, and it needs to be specific to what you're wanting the resident to take from that procedure, which is a lot of work.
right, it'd be great to get to a point where I think the scores are really meaningful for each procedure that we kind of grade residents on.
Yeah. There was a question from one of the residents.
Yeah, I was gonna, if you got him, you can go for it. I have a question from Dr. Aber Davies and Dr. Hannell. Do you have this?
No, go ahead.
Dr. Hannell's question is, does the adaptation of simulated education require a significant cultural shift in how we view education? And is this lecture our next best step towards that cultural shift?
I think it probably is going to have to be a cultural shift in that there needs to be a cultural shift to making this meaningful, making it count. The challenge is going to be finding the time to build this into the curriculum and to make it consistent across multiple different subspecialties as residents progress through their residency training. So it is going to be a cultural shift. It's just hard to say exactly what that is going to look like, and I think it's going to require input from everyone in the department to see how that's going to look in the future.
And Dr. Aber Davies texted me, CSATS is currently doing attending surgeon improvement through feedback video. What is the place for that in orthopedic surgery?
Well, that sounds really interesting. So CSATS is that crowdsourced assessment of technical skills. So I wasn't familiar with that, but that sounds like a great opportunity. So basically, the concept is to have attending surgeons improve their surgical skills by sending clips of their own surgical procedures to other online workers. So I think that would be a potential way for people to.
Is he referring to like the Amazon Mechanical Turk?
Yeah, Mechanical Turks. So yeah, I'm not familiar with that.
So
but that's really
urology,
cool.
I know, has in this institution has gone to town with that technology.
I've heard about other people, also like in Harvard, examples of inviting senior surgeons to come into the operating rooms of another surgeon. So, just to come in and observe and give some feedback. So that'd be not the CSATs, but a surgical expert to continually improve our skills. I think you need to do that in order to really kind of get to the next level.
I just had a very general question for Dr. Hulet or the residents, or any of the residents here. How do you feel about this technology? Do you feel it in its current technological sophistication that it's actually helpful?
So I guess I'll start, but we kind of talked about this a little bit before with the OSO VR system, how it's a little clunky, and I kind of mentioned on the Symbionic simulator, I found it really helpful as a junior resident, like as an intern or as an R2 practicing with some of the very basic things. But after you get into the OR and you're doing like the actual thing, or you're doing the actual thing on a cadaver, it can just be really frustrating because it's not very realistic and that haptic feedback is not super accurate. The OSO VR system that we have doesn't actually have incorporation of haptics. And it has to be calibrated just right, or else when you're like going to grab something, like you'll reach to grab the mallet and like nothing happens, that kind of thing. It looks like you've experienced that on there. So I think particularly for junior residents, for some of the more basic skills, the arthroscopy simulator can be very helpful, and those learning curves show that. And then for technology like the OSO VR system, I think specifically like the main benefit for that is going to be, instead of trying to memorize the huge PDF of like each technique guide for each total knee that the different attendings use, just to kind of cement the steps, because you can look at the wall and you can take like, what's next? I'm going to take like, what size pin am I going to take next? Or like, the next step, the tibial cutting guide, and being able to know like on that system, what are the next steps? And that OSO VR system is nice because you can have it on a setting where it will highlight what the next one is at the beginning. And then after you've gone through it a couple times, you can turn off that setting so that you have to recall what it is. And then it'll show you your scores. So I think especially like for junior residents who are becoming familiar with new devices, then that system is particularly helpful. But I think they probably have a long way to go, and I think they'll probably improve a lot.
Probably attending's getting used to new devices as well, just to kind of run through a few reps before you're in the operating room. One of the questions from the residents, from Dr. Kark, was, with residents being perceived as less prepared for fellowship and the breadth of knowledge increasing, is there a role for extending residency? And I think that's also an interesting question. There is some studies that have looked at that question, and it's an interesting, it depends on who you ask. When you ask these fellowship directors of general surgery programs, they're saying that fellows are, unprepared when they start fellowship. But when you survey residents and fellows in different specialties, they'll often say that the current duration of training is long enough, and that they're ready to move on. They would want to have some changes in how they're trained, but the number of years, they feel that it's enough for them to go into practice. So I think that would be a big cultural shift to have extension of residency or fellowship, but it is a question that comes up with these sorts of discussions. All right.
Thank you.
Thanks very much.
Thanks, everybody.